Hi everyone. My name is Jacqueline Posada and I am a psychiatry hospitalist at GW where I work on the inpatient unit, consultation liaison, and occasionally in the ER. I, with the other hospitalists, have worked to put together an orientation to help you stay safe wherever you're working in GW Hospital with the psychiatry service, help you understand your patients, and be an effective member of the team. So we're going to cover these objectives, and the goal, we want you to feel safe while you're learning, be able to connect with your patients. As with every rotation, there are specific expectations and differences for how the service works. We're also going to talk about some interview skills and essential questions since the psychiatric interview is different from what you've done in the past. And then we're also going to go over effective documentation for progress notes and discharge summaries, which is what you'll primarily be doing, and go through a little Cerner tutorial so you know how to use the workflow M page. So first, safety and de-escalation. This should be covered in your orientation with Dr. Saminow, but I just want to say that you should always have an exit route. So for example, when I round with the students in the therapy room, which you'll see, the patient is always seated furthest away from the door. That way, if the interview were to change in a split second and the patient were to get agitated, we would be closest to the door for an exit. On the unit, it's different from other wards. It's just important to be mindful of your surroundings and really aware of the interactions between patients as they socialize with each other and patients and staff. And, you'll notice good things like maybe the way a patient is improving as they're on medications and with the milieu, which are the other patients. But you may also notice the beginnings of agitation, and you can help the rest of the staff members, the doctors, and the nurses prevent agitation. So if you see something worrisome, which we'll talk about in the next slides, please inform staff, whether this is the technicians who are very good at de-escalation or the nursing staff, the same. So agitation exists on a spectrum. It's not like a patient goes from, well, rarely does a patient go from 0 to 100. There are usually signs of agitation. So this is what I mean when I say be mindful of your environment. So if you see a patient who looks upset, maybe you can hear their voice getting a little bit louder when they're talking on the phone. If a patient is talking to you and they're saying that they're angry and you feel that they're quite hostile, or they stand up and they get too close to you, these are signs that agitation might be brewing, and there's ways to de-escalate it verbally, or sometimes a patient can be offered medication to help. I think some really key signs that I would encourage you to look for as a student would be if the patient is really angry or irritable, if they're trying to intimidate you. Often if a patient is repeating the same question to you, if they're repeating your question back to you, that means that they're getting angry and it may be time to just step away. On the unit, you'll notice that some patients pace and they're restless because of their medications, or perhaps they're bored, but you will start to notice a difference between that restless agitation, that restless pacing, and that pacing of agitation. Maybe they're getting closer and closer to the red line, maybe they're approaching the nursing desk in a bit more of a hostile way. Just kind of keep an eye out for the behaviors that you see listed here, and if you see something, say something. So these were covered in the orientation that you received from Dr. Saminow, but these are considered the domains of de-escalation from a working group of emergency room psychiatrists. I would say the most important thing for you as a student to do is on the left-hand side of the screen, which is respect personal space. You should always be, out of arm's reach of a patient. Don't be provocative. Really, there's no winning in an argument with a patient. Don't stare anybody down. It's just good. Like if you feel like things are getting out of hand, just step away. I'm going to go talk to the nurses. I'm going to talk to the doctor. You can say all of those things and just step away. If a patient is getting agitated, it's better for just one person to speak to them and to kind of keep the stimuli limited. So that's what we mean by established verbal contact. Be concise when you're talking to patients, and especially when they're agitated, they're going to have a hard time processing complex language. And, if there's something that you can identify for the patient that they want, maybe they want a drink of water, or, a lot of patients, they don't have the creature comforts of home. If they just want a towel or something, you can get that for them if that's going to make them, less angry, less agitated. What's said here, as you see on the right, these are more the domains of de-escalation that involve the actual, like, verbally de-escalating, talking to the patient, and trying to either avoid or delay medications. And these are great things to observe on the unit. So trauma-informed care, you may have covered this in your other rotations, perhaps OBGYN or family medicine. I think it's essential in psychiatry. The idea of trauma-informed care is that it realizes the widespread impact of trauma. It recognizes signs and symptoms of trauma, and we'll talk about why this is so important. And it responds by integrating knowledge about trauma into our policies, procedures, and practices. And we seek to resist re-traumatization. So certainly GW Hospital and our psychiatric unit is not perfect. Unfortunately, a psychiatric unit can be re-traumatizing for many patients if they've experienced trauma on a psychiatric unit, or perhaps it reminds them of other places. But we as individual providers can do a lot to make the patient feel more comfortable and act according to the principles of trauma-informed care. So this slide is just to show that so much of what you're going to see on your psychiatric med student rotation, but also a lot of your work in medicine is really related to violence and trauma. So what you'll especially see is that we work with a lot of patients with substance use disorders, a lot of individuals who are homeless or have housing insecurity, clearly mental health issues and chronic health problems. And as you start to get to know these patients and, inquire about their backgrounds, you're going to see that there's a lot of trauma. And I just want to remind you that it's not just the physical or sexual trauma, these things that we ask about pretty explicitly. For a lot of people, it can feel sort of intangible. Maybe it's emotional neglect. Mom and dad weren't around, whether because they were working all the time. There's also family histories of addiction that make parents unavailable. There can be emotional abuse, not getting enough love or attunement from family members. There can be food insecurity. There can be violence in the neighborhood. So, even if a person says everything was fine in my childhood, as you get to know them and as you ask questions or kind of listen to their stories, you may realize that there's actually quite a bit of trauma that's unaddressed. So this is just a slide to remind, you all of what's considered the ACE study, or the Adverse Childhood Event Study. And this is quite a large study from a Kaiser Permanente group in the 1990s. And it was a landmark study basically showing that when children have these traumatic or these adverse events in their childhood, it increases their risk for other problems in adulthood, whether that's mental health issues or chronic medical issues. So I think what I like about this one is it reminds us that, we think often of substance use. Substance abuse is a disorder, but sometimes, we can sort of be blaming on the patient. We may not think about their background. And as pointed out this slide here, a person with a high adverse childhood event score, they have a huge increase of being an IV drug user. And that's why we need to think about, the experiences, the childhood experiences that lead our patients to end up onto the psychiatric unit. Trauma is so common in, I would say in the population in general. Many of us know trauma survivors, we may be trauma survivors, and especially on the psychiatric unit, I think it's just the norm. And also on the consultation liaison service and in the ER. So just keeping in mind that pretty much just assume that anybody you're talking to in your psychiatric rotation has experienced some type of trauma. I think what I just want to point out here is that, like it says, 80% of people in psychiatric hospitals have experienced physical or sexual abuse. And then on the next slide, individuals with suicidal ideation and suicide attempts also have a background. They're very likely to have experienced trauma in their background. And, this is there's a lot of environmental effects. You can even ask, nature versus nurture. There's certainly generational trauma. But the idea is that whether it's that trauma predisposes individuals to mental illness, we're going to see a lot of our patients acting out the consequences of having been on the receiving end of trauma. And it's, our duty to be quite sensitive to this. So, the physical environment can contribute to a sense of vulnerability. I think of this as especially important in the hospital and particularly the ER. So what hurts somebody who has a history of trauma would be touching them without consent, invasive procedures and questions, which is certainly what we do on psychiatry, feeling exposed in the medical gown. On the psychiatric unit, the patients have to wear the paper scrubs, which can, make them, some people talk about feeling dehumanized and institutionalized, and that can feel very re-traumatizing. Uncomfortable furniture, cold, non-inviting colors. Like, this is a description of many hospitals. But how can we help? We can help by ensuring privacy during interaction. So making sure that maybe we take the patient back to their room to talk, an emphasis on consent, especially when it comes to medications or therapy or talking to family. I try to make this a shared decision making so the patient knows that they're included, and then just trying to make the environment more comfortable as possible. Our policies and procedures and interactions can also influence patient perceptions of safety and care, and like we have discussed, could re-traumatize. What hurts patients is that rules and promises always seem to be broken in the hospital. The classic, I'll be back in a few minutes. I really try to be accurate when I talk to patients saying, I'll be back in an hour, 2 hours, I'll be back by maybe even in the afternoon, 3 o'clock. Just being honest is better than being prompt, honestly. I think it's important to remember that we are talking to the individual one-on-one, and even though we are a representative of the hospital and a healthcare provider, I try to avoid words that are like, your chart says here, or the nurses have said. I try to make it really personal when we talk to the patients. So again, just setting realistic expectations when you talk to the patient, but trying to be warm, acknowledging their vulnerability in the ER, but definitely anywhere where they are in the hospital, and sort of checking one's countertransference or reaction to the patient, and remembering that mental health, substance use, and even physical health symptoms can be a person's way of coping with their trauma. So let's go through some psychiatry-specific expectations and hopefully some tips that will help you master the rotation. So confidentiality, I think, important in healthcare, but clearly very important in mental health. These are considered the 5 C's of confidentiality, and when you can break it, so to speak. So we're going to ask you to break confidentiality, so to speak, to do things like get collateral or request records. And when can you do this? So in red are the most common reasons that you're going to be able to do this on the unit. So the first is that a clinician may release confidential information with consent. So when a patient is admitted, in the admission packet, they usually sign a consent form to talk to their mental health provider, their outpatient mental health provider. Make sure that's in the chart, make sure that's been signed. If they haven't, get it signed. Some patients really don't want you to talk to family, and for me that's always a red flag. Sorry, I should say don't want you to talk to family or other treatment providers. For me, that's a red flag, because talking to other providers and family is a way to provide comprehensive psychiatric care, but they may have a reason to refuse consent, and it's good to talk to the patient about why they don't want you to talk to somebody, and also try to get that consent over time. Another reason why we are maybe able to break confidentiality is to continue treatment. So we can release confidential information necessary for the continued treatment. So this is sort of the rule that I use in order to call a patient's healthcare provider or their psychiatrist. And it's covered under the minimum necessary rule. So we're providing the minimum amount of information necessary to the other provider to make sure that there's good continuity of care and safety. So I think an example is if you are suspicious that a patient is abusing their benzodiazepines or another narcotic or something, they're asking for a lot of these medications, but they're saying, no, you can't call my psychiatrist. We can talk about other ways to get that collateral and that information, but I would probably still call a psychiatrist or the primary care provider, because to me there's a red flag of why the patient doesn't want me to talk to that person. The other reasons why we might need to break confidentiality here are to communicate a threat. This is the Tarasoff exception, which means that it is our duty to warn others who might be the victim of violence from a patient. So this is usually in the context of homicidal ideation. We may call the stated victim. We also talk to security in our hospital, who are the liaisons to Metropolitan PD. Things that you probably won't be involved in, but would be to comply with the law. So providing confidential information sometimes to a parole officer or CPS, and then a court order. So we're going to ask you on all of your rotations to get collateral. For us, it's an essential part of psychiatry. So collateral is gathering information about the patient from their known contacts. So this, we'll talk about examples. We think it's essential because, sometimes you need that third person perspective to make the diagnosis. It's not necessarily, sometimes patients withhold information, that's true, but sometimes they don't even know that they're withholding pertinent information, and family members and friends and outpatient providers are witnesses to the behavior, so they can give you that information. So some questions that would be helpful to ask when you're calling for collateral would be asking about recent stressors, signs and symptoms of illness noticed by the family, if they have any understanding of compliance, does family help with their medications, past presentations to psychiatric hospitals. And I would say this is especially important in mania and also psychosis, because these illnesses can really cause a lack of insight, and sometimes people have had many manic episodes and can't even remember them. So the important part is that, we just need more information from collateral. Talk to your supervisor, whether it's the attending or the resident, about what specific questions they'd like you to ask. This is a good place to start. As discussed, it's best to get consent from the patient. I mean, you must get consent from the patient on the psychiatric unit to call their family. I can think of few circumstances where I've called the family without consent, and I've considered them emergencies. And you don't want to break that trust and rapport with the patient. For patients in the ER, so if you're on your night float rotation, patient consent is actually not required to get collateral because it's considered an emergency because they're in the ER. So you can call the emergency contact, you can call people who are listed in the chart, but it's important to maintain privacy. So if you're calling for collateral, think of it more so that your job is to get information. So you should be asking the questions and giving as little information as possible, so as not to sort of compromise your trust with the patient. That is, unless the patient says, oh, you can tell my family anything, I don't care. I usually ask the patient, when I'm calling family, is there anything that you don't want me to disclose to your family? And then that gives us time to talk about those issues. So examples of collateral: calling friends, family, or provider, checking CRISP, which you can do through Cerner, calling DC Access Helpline, the on night float, and CL. This is going to be a great way to help the resident you're working with and the attending, and it has to be done from a hospital phone. Requesting records, I think sometimes I don't do it enough because I think it's going to take a long time, but once you get the form in, it can usually be pretty fast and helps. I'm going to show you in the Cerner tutorial how to check the external RX if you don't know already. And I think a really underrated form of getting collateral is actually reading the chart to understand past presentations. For better or for worse, a lot of our patients have been in the hospital over and over, and we don't really read the chart to get that thorough understanding of the patient. So going through the chart can be a huge help to the patient and the team. So on the psychiatric unit and in psychiatry in general, boundaries are a very special topic. I mean, they're important in all of medicine, but I think we talk about them more in psychiatry because you see them crossed by certain patients, and we'll talk about those patients in coming slides. But boundaries are a mutually understood, unspoken physical and emotional limits of the professional relationship between patient and the physician. So, of course, we need to touch our patients for the physical exam, but we ask permission first. Some doctors may hug their patients, and certainly I have been known to hug a patient who I've seen in the long term, but that's not an appropriate boundary to cross on the inpatient unit. And so a lot of them are unspoken, and we'll talk about what to do when they get crossed. But, boundaries are part of all relationships. And as professionals, we want to model healthy relationships by setting appropriate boundaries. And you're going to see on your rotation that a lot of individuals' problems that we see on the psychiatric unit, are, if not caused, they are worsened by poor boundaries on their part and often from their family members. So these are two important categories of boundaries. So a boundary crossing, here on the left side, is a minor deviation from traditional psychotherapy that neither harms or exploits the patient, and in some cases can advance the alliance. So, for example, if you're seeing a patient in your outpatient clinic, maybe you're their therapist, or I think even other physicians, and they give you a small gift from their vacation. That's a boundary crossing. It's not perhaps like a usual interaction that a patient might have with a doctor, but it's a way to have a bond. It's a way of the patient to show their thanks, and by you receiving that present, it's a way to kind of show the patient that you're interested in their personal lives and not just their health. And this is why a lot of organizations like the government, the VA, say that a doctor or a provider can accept a gift under $25. A boundary violation is something that does harm to the patient. It may be exploitation, either it's psychological, sexual, financial, emotional, and it's based on the patient's dependency needs. So a classic example is if a psychotherapist has sex with the patient. So I have here a picture of Marilyn Monroe, who had a very close relationship with her psychoanalyst, and it's now been speculated that they actually had a sexual relationship. And, Marilyn Monroe is, it's theorized that she had borderline personality disorder. And as we'll talk here, there are certain patients who, because they, in their disorder, given their past experiences, they have poor boundaries. And it's our job as the professionals to set clear boundaries and show them what it's like to have a healthy relationship. So certain patients are more likely to attempt a boundary crossing, and that includes, particularly on the psychiatric unit, bipolar patients who are hypomanic or manic and intrusive. So intrusive usually means a manic or hypomanic patient will be standing too close to you, maybe asking personal questions, maybe making sexually explicit remarks. I'm not going to go into how to address all boundary crossings here, but it is, I think if you feel uncomfortable, it is always okay to say to the patient, I don't feel comfortable with this question or this topic, and I'm going to step away from this conversation. The second type who are likely to boundary cross or attempt would be individuals with borderline personality disorder. It's part of the pathology to have poor boundaries. That poor sense of self makes them more likely to want to connect really intensely with somebody, and that may be the provider, that may be you as the medical student, and that may include like standing too close, asking personal questions, even imitating you. So, if that occurs, talk about it with your supervisor. Psychotic individuals who struggle with reality testing may have a hard time with boundaries, and these are just some other examples. Individuals with impulse issues, history of childhood sexual trauma. Again, this has to do with not having had a background where boundaries are strongly enforced, and it's not that it's anybody's fault, but you have to imagine that if there is physical abuse or sexual abuse, the usual parental-child boundaries were not maintained, and that's going to impact their ability to function as an adult. And then naive or inexperienced patients, so to speak. There might be patients who have never been on a psychiatric unit or seen a psychiatrist, and they don't know that they're not supposed to ask the psychiatrist, 100 questions. So it's okay to kind of explain the relationship to individuals like this. So kind of ending this section, going with the flow, we have great attendings on the psychiatric unit, but they each have their own style in terms of writing notes, how they round, how they interact with patients, and teaching. So just take that as an opportunity to learn different styles. On some of the rotations, especially during the COVID-19 surge, there are a lot of students. So the residency attendings are going to do their best to assign you cases and tasks to help you learn. And, on the psychiatric unit and CL, it's busy, so we need your help to provide high quality care to the patient. So don't be afraid to take initiative and make suggestions. So some interview skills and some questions that will guide your notes and your interviews on all of your encounters. So, you're going to have lots of time to talk about initial evaluations and how to do a psychiatric interview, but this is just the basic structure that I suggest. So what I think is important to remember is all of the patients, so on 6 South, all of the patients who are the new patients will have had an initial evaluation with the resident overnight or the attending from the day before when they were admitted. And, the follow-up evaluation is a time to clarify the diagnosis, anything that was sort of left unanswered. So when I meet a new patient, I usually leave them 5, maybe 10 minutes if it's not a busy day, just dedicated to the presenting complaint. I let them talk about what's bothering them, and I try to direct the answers to what's the problem and why now. So why did they come to the ER today and not 2 weeks from now or not 2 weeks ago? What is, the stress or the environment that's making things so bad right now that they're on the psychiatric unit? Because those details are important. And then you can think of an initial evaluation as, it's always helpful to clarify a diagnosis because we don't know how well the diagnosis was made before unless it was made by a colleague who you trust. But these initial evaluations are a good opportunity to kind of screen for all these psychiatric disorders in general. So I use the abbreviation MyPass. So what that means is that in your initial evaluation, you should try to ask about the mood disorders, which are depression and bipolar disorder, psychosis, so these might be symptoms of schizophrenia, the positive symptoms and the negative symptoms. Anxiety, I would say the 3 most common types of anxiety that you're going to see on the inpatient psychiatric unit and CL will be PTSD, panic attacks, and generalized anxiety disorder. Substance use disorders. So I encourage you at the very beginning of your rotation to review the DSM-5 criteria for substance use disorders and think about, the questions that you can ask to elicit that criteria, because it's not just do they use or not, but it also has to do with how the substance use disorder impacts the person's ability to function in day-to-day life, legal issues, family, and also physical symptoms. And then the final S is safety. So the first question is to ask, does the person have a gun? Which is less common in DC, but wherever you end up working, like I just left Virginia where gun ownership is much more common. It's an essential question. But basically you just want to ask, is the environment safe? So does the person have like a year's worth of pills in their bathroom? Something you would ask the patient, something you would ask the family, and in general, just a risk assessment of, what's going on at home and how can we help keep the person safe when they're discharged. So follow-up interviews, this is the bread and butter for all of the medical students, probably even more common than doing an initial evaluation. So I would say, progress notes should focus on target symptoms, and so those are the symptoms of the primary psychiatric disorders or personality disorders, and then also what's important to the patient. So examples of target symptoms would include mood and psychotic symptoms, anxiety, drug cravings, suicidal ideation, sleep, changes in thought content, which means like changes in suicidal ideation, and their desire to connect with loved ones. So, for example, if a person has major depressive disorder, I would ask them something like, I would certainly ask them how their mood is today. I would ask about suicidal ideation. I would ask them, what symptoms, what are the things that most interfere with their ability to function? And they may tell me, oh, it's fatigue or poor sleep or ruminations. And then I would continue to follow up with those day to day. And, with anxiety, this is the place where when you're told by your supervisors to review the DSM, it's because we want more detail in the notes than just like patient is feeling anxious. Well, what does anxiety mean? Are they having intrusive, anxious thoughts before they go to bed? Are they having a hard time concentrating in group therapy because they're so worried about what people are thinking about them? Like, these symptoms are specific and they can be targeted with both medications and specific therapies and coping skills. So figuring out those really specific target symptoms are going to help us effectively treat the patients. It's really helpful to ask the patients about their goals for their treatment on the unit. So what do they want to achieve by the time that they're discharged? And this is a good place to understand where the patient is coming from and their motivations, but also to set clear expectations. So, a psychiatric unit, we're not going to get a person back to 100%, unfortunately. We usually have, 5 to 7 days. So we can set that expectation of, we hope that you will have less suicidal thoughts, that, maybe your sleep will be back to normal again or getting there, and you're going to have, fewer panic attacks, but it's not going to be down to 0. So a good place to, check in with the patient of what they expect, but what you can realistically provide. And then also I like to know what the patients want to achieve in the next month or so. And again, this is kind of going back to this positive psychology, motivational interviewing, knowing patients' motivations, knowing what their values helps us provide effective treatment, but also it can help us elicit target symptoms that they may not even be able to talk about until they talk about what they want. On these inpatient services where we're providing acute treatment, you should ask about response and reaction to recent interventions, such as medications, or even like group therapy or psychoeducation, kind of following up on the next day, like what did they learn, what did they think about that, what have they been doing in group therapy. For medications, please, please, please ask about specific side effects. So, within the first week of your rotation, you should really know the common side effects to SSRIs, antipsychotics, and mood stabilizers. And instead of asking, did you have any side effects or has anything changed? I like to go through a list with the patients dependent on the medications that I started. Because, for example, like patients have physical comorbidities. And so if we start an SSRI and the patient has a headache the next day, but they also have high blood pressure, it's going to be hard to figure out which one it's from, and they may think that it's from the high blood pressure, not the SSRI. I mean, the point is that it's important to be specific. And like we kind of talked about, just make sure you ask about how mental illness impacts the patient's functioning. I mean, that's the basis of a DSM diagnosis, that how do these symptoms interfere with functioning? And a lot of our patients are going to have comorbid medical issues. So I think it's a great question to ask. Well, does your depression get in the way of you taking care of your diabetes? Or, you get the point. But just remembering that the body is a system and mental health is going to impact physical health. So making your note count, and I should also put in parentheses, like, making life easier for your attending or your resident. But just think that, you should be writing your notes to support diagnosis. So in your interval history, you should be documenting DSM criteria. So sometimes in the pre-round in the morning, it's very common for the patients not to want to talk too much. Maybe they don't give that many symptoms. At least when I round, we get a lot more symptoms during the table rounds. We talk about DSM criteria with the patient. I want those criteria in the note. And I don't think that's just me. Like, the note is there to justify the diagnosis and the treatment. So that means adding that information to the interval history. And you'll be able to make the note meaningful and know what to ask by identifying those target symptoms and figuring out what's better or worse and why. So meaningful diagnosis just means that when the next person reads your note, they know what happened in the encounter and they're not just like totally clueless to what you were doing with the patient for the last 7 days. All right, so we've covered it. I would actually encourage you just to take a screenshot of this slide, because if you can cover these things in your notes, you're going to be golden. So salient information that you should comment on. Please comment on overnight events. So this means going through the nursing notes and looking at the MAR to see if the patient received PRN medications. This is particularly important if we're treating the patient for alcohol withdrawal. You're going to talk about those target symptoms that we have discussed. You're going to document the side effects or the lack of side effects. talk about that response to interventions, talk about the patient's goals, and talk about functioning. So, maybe you're not going to cover all of this in every note, but if you can cover some of this, it's really going to it's not just about documentation. You're going to provide more effective treatment because you're going to know the patient better. Mental status exam. Your progress note is your opportunity to practice your mental status exam. Please don't skimp on the details because in psychiatry, the mental status exam is the physical exam. So what I like to tell students, is that when I read your mental status exam, it's like I want to have been in the room with you. I want to know what the patient was wearing, what they look like, what were they doing, like if they were lying in bed with the covers over their head, or did they prop themselves up on the pillow and they were making good eye contact with you. Like, give us some details. Probably my pet peeve is when students write that the affect is congruent and the mood is okay. I know you guys have lectures on this, and again, this is stylistic, but for me, I just like a detailed mental status exam. I want the mood to describe how the patient's feeling. Like, even if they say okay, well, do they look sad? Do they look irritated? Do they look dysphoric? So kind of giving those details. So again, that the mental status exam is supporting the documentation, supporting the diagnosis, and also why the patient is even in the hospital. And so if you have questions, please ask your attending or resident. There are tons of resources online about good mental status exams, especially on YouTube, where they'll even do patient interviews and talk about the mental status exam. So please review the vitals and labs every day. I know in psychiatry it's easy to think like the patients are healthy, it's fine, this is all mental illness, we don't need to worry about it. But we are doctors in psychiatry and we care about the mental and the physical health. And so mental health affects physical health and physical health affects mental health. So as I put it here, do your part to banish this mind-body dualism. They're all connected and we have to take care of the physical health of our patients. And the reason why this is actually just so important is that a lot of the patients that we see, especially individuals who are homeless, anybody with severe mental illness, they have a 10 to 25-year reduction in their life expectancy. So if we catch somebody's high cholesterol or their diabetes or their STDs, or we put them on the appropriate prophylaxis for metabolic syndrome, we are extending their life expectancy. And, if they feel physically better, they're going to feel mentally better. Okay, so moving on to assessments. Think about the assessment part of your note as your opportunity to discuss why you think the person meets the criteria for their diagnosis. So for me, a good assessment can be copied into a discharge summary to help future providers understand the thought process. We're going to go through examples of types of assessments, but I will say, as a student, I think it's okay to copy in the initial assessment from the resident in the H&P, but it needs to be updated as treatment progresses and add, based on your discussion with your supervisor, adding information about the diagnoses, kind of important details from the hospital stay. And so as other information that assessments include are biological factors, social factors, and risk assessment. So this is sort of a brief slide about the classic biopsychosocial assessment, which I think you guys are expected to use in your OSCE. And for me, this is a go-to when I'm tired or I'm not feeling very creative. I mean, I guess the point is, like, if you include something from the biological, psychological, and social aspect of the patient's life, you're going to be thinking holistically, and that's going to give you a good idea of who the patient is and how to treat them. So biologically, that means thinking about things like a family history of psychiatric and medical illness, so essentially genetic loading. What medical and neurological illnesses do they have? Realizing that like uncontrolled diabetes is going to contribute to depression, or vice versa. Medication interactions, and drug and alcohol use. I put drug and alcohol use in biological because these are chemicals that are entering the body and changing neurochemistry, and I think that's where they fit. Psychologically, to me, I mean, I think this is a little harder, but just thinking about like what personality traits do you observe the patient to have? If you're hard up on personality traits, then thinking about their coping skills or strategies. So is this somebody who, whenever they get sad, they binge drink alcohol? You can put that here. They lack, adaptive coping skills. Thinking about the patient's response to stressors, thinking about past trauma, and also the history of or current psychiatric illness. So a lot of people will write in the psychological area, patient has a history of depression, PTSD, with these prominent symptoms. And then finally, social. So, the social environment is going to impact how our patients can even take care of their physical and mental health. So including it, I think, is an important part of the assessment. So starting with just the home environment, we treat a lot of homeless people at GW in general, but in psychiatry, think about their finances, employment, relationships, whether that's romantic, family, or friends. I think more recently it's interesting to think about the impact of COVID on a person's life, including their social isolation. And then I also usually put connection to outpatient providers because it can mitigate suicide risk, and also it's a sign of compliance in a sense. All right, so when you're making your plan, I am always open to suggestions from students. We want your help. This helps you learn if you're thinking about the plan critically. So review the chart and make suggestions in your plan or in the progress note that you're submitting to the attending or the resident. Update the plan on a daily basis. I know this is kind of basic, but old parts of the plan get left in the in the updated plan all the time, and I delete them. So, the plan should represent what's happening on that day. Again, talk to your resident. If you want to leave some historical information in the plan, like if you want to include results, that's okay. But for example, a common one is under schizophrenia, if you've put, order hemoglobin, A1C, and lipid panel. Well, instead of leaving that there for 3 days, if it results, you can say, the lipid panel and hemoglobin A1C have resulted with, with these values, etc. So just make sure that it's updated. There's a lot of copy and pasting in medicine in general, so just make sure that you edit and update anything that you copy and paste either from the day before or from another clinician. And if you write the note before you round, again, make a suggestion for management. Talk to your resident before you write your note if you want to make sure that it's accurate. And then you can suggest medications, therapies, coping skills, collateral, and psychoeducation. All of these are fair game. It's not just about titrating medications. So you are going to be writing a lot of discharge summaries as a student, especially, I'm sure, like you've done on other rotations. They're a little bit different on psychiatry. So again, I would say, take a screenshot of this slide. For me, these are all the things that I want in a discharge summary. I know that I am guilty of perhaps writing overly detailed discharge summaries, but I would say if you can include most or all of this, like, it's going to be the best discharge summary that anybody has read. So kind of going through it and rationale, it sounds obvious, but make sure that the diagnoses are up to date. And yes, this is usually something done by the resident or the attending, but if you see like an old diagnosis in the list of the auto-generated diagnosis or one that doesn't make sense, please tell us and we'll remove it. In the discharge summary in the hospital course, I usually include supporting information, especially if a diagnosis has changed. So for me, a very classic one would be maybe a person comes in with a diagnosis of bipolar disorder, but in fact, I think they have, alcohol use disorder and borderline personality disorder. Then I'm going to talk about why I changed the diagnosis and the symptoms. Include information about med changes, the rationale of the change, and discuss the side effects that were experienced. Please note any aggression or agitation or behavioral issues on the unit. For the residents on call, I know they go back to the discharge summaries to make sure that they're not admitting somebody with a history of violence, or if they are, they can give the nurses the appropriate heads up. So document use of PRNs. We are going to see so much substance use disorders in CL and 6 South. 6 South is where you'll be writing the discharge summaries. So please document how it was addressed. If the person had a withdrawal syndrome, how was it treated? were medications offered, like naltrexone or other medication-assisted treatments? Were they discharged to a 28-day program? And if you did motivational interviewing, what did you learn about the patient? What are motivations that can be used for future encounters? Document if you talk to collateral. This is usually family and just, a 1 to 2 sentence summary of what they said. Document if you talk to the outpatient team. This includes the case manager, psychiatrist, or therapist. This is more so good documentation to note that you did so. If there was a family meeting, please document that you had it and what was the outcome. And I also think it's important to document pertinent negatives. So if a patient didn't attend any group therapy, if they remained in their room the whole time, if they didn't take medications, document this. We read the discharge summaries. I read them if a patient has been hospitalized previously. When I'm working in the ER, I read them, and all of this is information that I want to know. And also, discharge summaries are faxed to the outpatient psychiatrist or provider, and they're uploaded to CRISP. So having useful information in the discharge summary, is our duty, I think, as a clinician. So a suggested structure would be in your hospital course to copy and paste the subjective portion of the H&P so the reader knows the initial presentation of the patient. And then one option is to just write a short summary of what occurred on the unit, including your differential and support for making or changing the diagnosis. So by short, I mean like 2-3 sentences. I mean, it doesn't have to be a novel, but this is the gist of what happened. And then you can use problem-based discharge summaries as long as you integrate the information shown on the previous slide. So let me show you an example. So I know this is a lot of text, but just kind of going over it. And again, this is probably more detailed than you may write, but this is what I would consider a pretty high standard for a discharge summary. So problem-based, we have the 2 diagnoses that we're working with. So for this patient, it's PTSD and a provisional diagnosis of borderline personality traits. So then I'll put, what I think support these diagnoses. So you see them here, the history of trauma, what occurred, the symptoms. Then I have a paragraph covering medication. So I talk about Zoloft was stopped due to sexual side effects, which were contributing to non-adherence, which new SSRI was started, how high it was titrated, what the patient reported in terms of side effects. If I suggest a medication to the patient, but they're not sure about it, I'll usually put it in the discharge summary because it's helpful information for the next provider. You see here in the 3rd paragraph that I've covered substance abuse disorder, so counseling the patient about their binge drinking, offering a medication, and then I included the borderline personality disorder here because for a lot of individuals with personality disorders, drinking or drug use is part of the impulsivity or trying to fill the emptiness, so that's pretty detailed. But then in this final paragraph, you see that I have documented the collateral, so that I talked to the psychiatrist, that I talked to them about future treatment planning, my suspected diagnosis, and then with the patient's permission that we talked to the family or the husband about the diagnoses, what to expect, and also that we asked the husband to make the environment secure. So as you can see, kind of covered all the things on that discharge summary, and it's not that long. Like this could be the whole discharge summary in the hospital course, but everything that the next psychiatrist might want to know and everything on this slide has been covered. Okay, so with that, we're going to move to a Cerner tutorial and just probably spend 5 to 10 minutes talking about how to write the note using the workflow M page.